Okay, cool. Thank you so much. Hello, everyone, and welcome to our May 2026 webinar. For those of you who are joining us for the first time, I'd like to extend a warm welcome. I'm Morgan Kowalski, NICU parent and FCC Task Force Director of Operations, and I'm so grateful that you took the time out of your busy day to be here with us. I can't go any further without acknowledging International Kangaroo Care Day happening tomorrow, May 15th. Skin to skin or kangaroo care is integral to practicing family-centered care, and we encourage you to celebrate in your unit. Each of our webinars is dedicated to the NICU children of one of our speakers. Today, we have the honor of dedicating this webinar to Jessi's daughter, Aurelia Barnes. Aurelia was born in August 2022 at 27 weeks and 5 days gestation after a home placental abruption and spent 75 days in the NICU. Jessi, thank you for using your family's NICU experience to center parents' voices in your work as a neonatal outreach coordinator and clinical nurse educator. All right, a little bit of housekeeping before we get started. Please mute your microphone when you're not speaking. Turn off your camera if you need to multitask. We ask that all questions and comments, whether spoken or written in the chat, remain respectful, non-discriminatory, and non-judgmental. Your cooperation helps us keep this space safe and welcoming for everyone. Thank you. All right. As a reminder, we follow the all-in meeting guidelines as created by Next Society. For those of you who are attending for the first time, we use first names to address one another to break down the hierarchy that exists in healthcare and to empower everyone to contribute. I'd like to acknowledge our webinar sponsor, Mead Johnson Nutrition, whose mission is protect, heal, and nurture in pursuit of a healthier world. Thank you, MJN, for sponsoring this webinar, and congratulations on over 120 years of leadership in pediatric nutrition. A warm welcome to our newest organizational partners. We look forward to working together to spread the word about family-centered care. We are now partnered with 78 internationally esteemed healthcare-based and family-led organizations dedicated to improving care for NICU babies and their families. This work would not be possible without your support. Whoops. The FCC Task Force's guiding principle is equal partnership between healthcare professionals and NICU families, which is exemplified by our leadership team and structure. I would like to acknowledge that our founder and executive director, Malathi Balasundaram, does this work on a strictly volunteer basis, despite it being potentially more demanding than her full-time role as a neonatal intensivist. Thank you to our family partners for their contributions to our work. I love that we are diverse in our infants' gestational ages and diagnoses, and that we represent birthing, non-birthing, adoptive, and bereaved parents. I'd also like to thank our multidisciplinary healthcare partners for volunteering their time and expertise. Many of these folks also have had NICU experience with their children. We'd like to welcome Alone Metric and Gold to our Executive Council of Healthcare Partners. Alone is a health innovator and CEO and co-founder of Skincubator NeoCare. Thank you to our advisory council who provide their insights on an as-needed basis. And last but not least, thank you to our board of directors for your time and support. I'm excited to share that we've got over 3,400 members from 49 of 50 US states, 9 of 10 Canadian provinces, and from 80 countries around the world. This month, our poll centers around skin-to-skin care practices in the NICU. Please help us support NICUs working towards strengthening this area of FCC by sharing your NICU's guidelines. And as I'm kind of moving through here, I will be dropping links for all of these resources and opportunities in the chat following my little spiel. We invite you to join next week's FCC Community Exchange session facilitated by Jamile Jackson and Marcia Campbell-Yao. They'll be discussing creating an environment best for babies and families, optimizing skin-to-skin care in the NICU. This session won't be recorded in an effort to facilitate a safe space for sharing, so don't forget to attend this one in person. If you haven't checked it out yet, please visit our new and improved website. More dynamic and user-friendly, our new site has gotten us away from the Google Drive links that aren't compatible with many hospital firewalls. We hope that you love the new look as much as we do and are grateful to Small Talk NICU Egg System for sponsoring this important project. Now live on our website, we encourage you to read and share our equity, diversity, inclusion, belonging, and justice position statement with your team and explore how your unit can mitigate harm for marginalized families. Going live on May 21st, our Present Study Toolkit will be a practical guide for NICU leaders and care teams to facilitate zero separation between infants and their parents. This toolkit has been an 18-month-long collaborative effort among 23 authors across the US and Canada, and we're so excited to finally share it with you. Don't forget to follow us on social media and tag us in your FCC-related work so that we can share it. I'd like to add that if you subscribe to our YouTube channel, you'll get early access to a recording of this webinar. And finally, we invite you to register for the 39th Annual Ravens Conference, Sensitive Issues in Sensational Times. While the date and location of this amazing event is changing, you can expect the same great topics, workshops, abstracts, and networking opportunities for those who work in the NICU space. Use code SPECIAL10 for 10% off in-person and virtual attendance. I'll drop links for all the amazing resources I just mentioned, and we'll hand it over to Rose for introductions of today's speakers.
Thank you so much, Morgan. We are super excited to be here. My name is Rose Horton, and I am the founder and CEO of Not On My Watch Consulting Partners, a proud partner of the FCC. And I'm excited to share the bios of our amazing speakers. I'm going to get right to it because I want you to get everything that they have for you. First is Dr. Veronica Barcelona. Veronica is an assistant professor at Columbia University School of Nursing. She earned degrees from the University of Michigan, her BSN, Johns Hopkins University, her MSN and MPH, and Tulane University School of Public Health and Tropical Medicine for her PhD, and completed postdoctoral studies at Yale University School of Nursing. Dr. Barcelona's research interrogates mechanisms and risk factors underlying adverse pregnancy outcomes with the goal of achieving healthy and safe birth outcomes for all. She has given numerous presentations at the state and national level, has published over 70 peer-reviewed articles, and is a recipient of multiple prestigious awards for excellence in research. She'll be followed by Jessi.
I'm so sorry to interrupt. I think they're having a little trouble hearing you. It
You can
sounds like
speak
their
up a little
volume is
bit
low.
louder.
Okay. All right. Thank you. Hold on just a second. Okay. Does that sound a little bit better? Is that any better? Yes? No, not really? Okay. All right. Jessi Barnes is a nursing professional development specialist with a passion for the neonatal patient population. Her nursing practice consists of high-risk perinatal care, neonatal intensive care, and a few years of nursing informatics, just to shake things up. Her passion for trauma-informed, family-integrated care fuels her professional work. In August 2022, Jessi experienced the NICU firsthand when her daughter was born at 27 weeks and 5 days after a home placental abruption, and we just had a chance to see her beautiful daughter. Experiencing the environment she knows and loves from the other side was exhausting, traumatic, but most of all, hopeful. Jessi holds a Master of Science in Nursing Education and in certifications in high-risk neonatal nursing, nursing professional development, and care of the extremely low birth weight infant. She is a graduate of the Trauma-Informed Professional Certificate Program and a Community Resiliency Model Teacher. She is president-elect of the Greater Atlanta Association of Neonatal Nurses. She serves as the co-chair for the Equity, Diversity, Inclusion, Belonging, and Justice Committee for the FCC Task Force, an international organization focused on improving family-centered care wherever babies and families are seeking care. I've had a chance to look at that statement, and it is phenomenal. Next, we have Adrienne McIntyre, CNP. She brings more than 20 years of healthcare leadership experience across perinatal, neonatal, and pediatric services in large, complex health systems. She currently serves as Assistant Executive Director for the Women and Children's Clinical Institute of Providence and a member of the California Maternal Quality Care Collaborative, CMQCC, Advisory Board. She contributes to statewide maternal health equity efforts. Adrienne is known for her human-centered leadership approach, strong operational execution, and deep commitment to improving outcomes for women, infants, and families. Last, but certainly not least of our esteemed panel is Cheniqua Morales, patient safety nurse at New York Presbyterian Brooklyn Methodist Hospital. She is co-chair of the New York City chapter of the Association of Women's Health, Obstetrics and Neonatal Nurses, also known as A1, and lead faculty for simulation and clinical training with the Partnership for Maternal and Child Health for Northern New Jersey. Cheniqua designs high-impact simulation and quality improvement initiatives that strengthen teamwork, communication, and readiness for obstetric emergencies. Known for her engaging and interactive teaching styles, she helps clinical teams translate evidence into safe, effective bedside care while mentoring future healthcare leaders. She is the 2026 A1 Excellence in Clinical Education Award recipient and is currently pursuing her master's degree in nursing. I just want to share one quick story with you before we get started. In 2022, while I was doing leader rounding at my organization, I had a conversation with one of our patients, and our goal for leader rounding is just to check in and see how things are going. And she shared a story with me that really impacted me significantly. At our organization, we have bedside shift report. She came in for an induction, and as inductions often happen, it became a serial induction. She was with us for several days. And she said to me, you know, everything went really well, but I want to share something with you. She said, every time the nurses were handing off at my bedside, they used the word failure, failure to progress, failure, failure. She said, I heard failure so many times that I thought I was a failure. When she said those words, it broke my whole heart, because the goal for bedside shift report is for transparency and for safety and for including the patient, not recognizing that the words that we use commonly in our specialty are stigmatizing and can have an impact. So I'm so very excited to share this work with you, because it really speaks to how we can change the narrative around our conversation and the words that we use and how we engage with our patients. So without any further ado, I'm going to turn it over to Dr. Barcelona, and she's going to get us started.
Thank you so much, Rose. And thank you, Jessi and Melody and everyone from the FCC that invited us here today to speak with you. Going to share my screen. And see if I can put this in slideshow. Okay, can you all see my screen and hear me? Thumbs up, great, thank you. Okay, so very happy to be with you all today. And thank you for that introduction, Rose. So I'm by background a community health nurse, always worked in maternal child health, and then went back to school to do my doctorate, and now dedicate my time to research and improving maternal health equity. So I'm going to talk to you a little bit about a recent project on stigmatizing language as an introduction to my colleagues' collaboration and work as well. Oh, let's see if I can advance the slides. There we go. Okay. So what is stigmatizing language and why is it important? Well, we know that disparities in maternal and infant health have persisted over decades. This slide shows from 2007 going through 2016. We know that Black and Native American women have had higher rates of nearly all adverse pregnancy and birth outcomes for decades. And when we look at the relatively rare outcome of mortality, we observe significantly higher rates of death related to pregnancy and childbirth among Black and American Indian, Alaskan Native women. And about 700 women die in the US each year as a result of pregnancy or its complications. We see the same disparities with American Indian, Alaskan Native, and Black women being 2 to 3 times more likely to die from pregnancy-related causes than white women. And we see similar trends as well when we look at infant mortality. And these trends have continued through the most recent data with a statistically significant increase in deaths for Black women in 2021 to 69.9 deaths per 100,000 live births. And of course, this is tragic not only because of the loss of life of the pregnant people and mothers, but also for children who then grow up without a parent or a mother. So when we look a little closer, we can see that with increasing levels of education, white individuals have lower mortality. However, with increasing education, Black individuals continue to have high mortality. And when we look at people with a college education or higher, Black individuals are 5 times more likely to die as a result of pregnancy or childbirth than white individuals. And about 2/3 of these deaths are considered preventable. So why do Black birthing people have worse outcomes? Much of the epidemiologic literature on this question can be summarized into 2 main camps. First is mother blame. So Black individuals have worse pregnancy-related health outcomes, including preterm birth, cesarean birth, pregnancy-related death, gestational diabetes, and pre-pregnancy hypertension. And mother blaming puts the risk or the responsibility solely on the individual's behaviors. However, this does not explain the bulk of the risk for these outcomes. Next, blaming socioeconomic status. Black birthing people are more likely to have less education, lower income, and to be publicly insured than white individuals. And low socioeconomic status contributes to limited access to preventive services, to control chronic illnesses, which subsequently leads to more adverse pregnancy outcomes. However, Black birthing people with higher socioeconomic status still have worse outcomes when compared to white individuals with lower socioeconomic status. So in recent years, systemic racism, including individual and structural racism, has been suggested as the true cause of racial disparities in perinatal health. It's also important to note that a 2025 review of maternal mortality done by the CDC noted that 1/3 of deaths were as a result of stigma, bias, or discrimination. So what is stigmatizing language? It has been defined as language that communicates unintended meanings, that can perpetuate socially constructed power dynamics and result in bias. It's been associated with poor quality of care, especially for people racialized as Black or Latina. And differential care may contribute to disparities in morbidity and mortality outcomes. Negative language may also spread implicit bias as subsequent clinicians read what was previously charted in the notes. And importantly, it may also affect patient trust and the relationship with their provider when they read the clinician's notes in their own records. So I conducted a study to understand and change institutional systems that reinforce racism and bias. In this study, we examined the electronic health records of all pregnant people greater than 20 weeks gestation who were admitted for labor and birth from 2017 to 2019 at 2 hospitals in New York. Building off work done in internal medicine settings, we used machine learning methods to examine stigmatizing language documented by clinicians in the electronic health record of birthing people. The aims of this project were to use machine learning methods, such as natural language processing, to identify stigmatizing language in clinical notes. Then we wanted to apply this algorithm to examine patterns of stigmatizing language use by patient race and ethnicity, and examine stigmatizing language and pregnancy-related morbidity outcomes. And we hypothesized that Black and Latina birthing people would have more stigmatizing language in their notes and more pregnancy-related morbidity than white patients. And the purpose, again, of this study was to examine systems that have bias built into clinical care and to reimagine and create new ones. So as we began this work, we were invited to write a commentary in obstetrics and gynecology, which you can read here by scanning the QR code. In this paper, we build on relationship-centered care and reproductive justice frameworks to describe how language used in written documentation, verbal communication, and behaviors can contribute to perinatal inequities. We adapted the power wheel to depict marginalized identities and power privilege language that may be recorded in the notes of birthing people. We suggest that stigmatizing language encompasses all of these identities, reflecting characteristics or traits that are preferred or more desirable in our US culture. For example, in order to marginalize birthing people, you have to define who has privilege. And the use of language in clinical notes that is not essential to care may in fact change clinician behaviors and affect patient outcomes. We provide examples in this article of preferred language, as well as interventions on the institutional, community, and societal levels to promote equal language use with the objective of improving maternal health outcomes. So here on the wheel, you can see, for example, some of the marginalized and power privilege characteristics that people might have in labor and delivery, postpartum, in even NICU settings, right? So where the parents are undocumented, have darker skin, less formal education, they may be more marginalized. And some of the power and privilege identities include being wealthy, having a small body size, cisgender, heterosexual. And I think it's important to note that no individual likely has all of the power and privilege or all of the marginalized identities. So if we can improve the care for people with any of these characteristics, will likely improve the quality for all patients. So what are some examples of some of the marginalized language that we found in our qualitative review of the patient notes? Here you can see a few examples. The patient claims she's in abdominal pain. Patient states her baby was, quote unquote, born dead. Patient adamantly declines weekly testing and attempted to provide type 1 diabetes education. However, the patient refused. Some examples of power and privilege language. Patient and spouse plan to hire a nanny after birth. Patient easy to engage, thought process logical and linear. Patient reports a 9-year nurturing marriage with husband who works as a financial analyst for a prominent bank, and husband is a neurosurgeon. This language that is not essential to clinical care, but instead underscores social status, may signal preferred characteristics of birthing people and in turn change the way those patients are treated relative to other patients. So we also looked at associations between the presence of stigmatizing language and 3 maternal morbidity outcomes. And this paper was published in Health Equity, where we looked at associations between several different categories of stigmatizing language use and low-risk cesarean birth as the outcome. We found that patients with any stigmatizing language, and especially language representing the difficult patient and unilateral authoritarian decisions category, had significantly higher odds of having a cesarean birth, using both the Society for Maternal Fetal Medicine and NTSV low-risk definitions. We then looked at chorioamnionitis, similarly finding that if patients had any stigmatizing language documented, they had a higher risk of having this infection. And those with difficult patient language specifically had a 33% higher risk of having chorioamnionitis. Finally, we looked at postpartum hemorrhage, finding similar things, that especially difficult patient language increased the risk of a postpartum hemorrhage twofold. They were twice as likely to have a postpartum hemorrhage if they had this language documented. So what are some documentation guidelines? While there's no gold standard recommendation for equitable documentation, there are some published guidelines, and these include documented in a way that is patient-centered, strength-based, only includes relevant clinical factors, avoids labels and blaming patients, recommending that clinicians stop weaponizing quotes. That's the use of quotations to highlight unsophisticated or lay patient language, or to place blame or cast doubt on them as a historian, that sort of thing. And also to avoid leading with social identifiers. So we don't need to use patient race and ethnicity in descriptions because that's not a biological variable that leads to poor outcomes. Racism is the exposure that leads to poor outcomes. And finally, we have some specific recommendations to share, and that includes something that Rose alluded to at the beginning of the presentation, which we've coined, we termed failure speak. So this is failure to progress, failure to thrive, all the failure words that we use. Instead, there we go. Instead, focus on the positive. Instead of geriatric pregnancy or advanced maternal age, just simply state the patient age. We all know that over 35 means increased risk for certain things. Instead of difficult patient language, patient refuses, claims, we can say the patient endorses, states, or opts not to. This respects the patient's autonomy to make decisions over their own body. Instead of demographic descriptors, we recommend asking their pronouns, addressing them as parent, or using their name. Again, avoiding the use of race and ethnicity for reasons I previously mentioned. Instead of disease first language, such as the diabetic in room 3, we can use strength-based language and say, patient is here with the mother for birth and has diabetes, right? And instead of elective abortion, induced abortion is the preferred language. So lastly, I'll just share some reflection questions that may help as clinicians are trying to think about how to avoid this type of language in clinical notes. So what am I trying to say about this patient? Is this information relevant to what the patient is being admitted and seen for? Why am I saying it like this? What are my intentions here at a clinical level? Is this symptom or behavior I'm documenting based on evidence given by the patient or a personal witness? Or could it be about the feelings I'm having about the patient, their lifestyle choices, or some other characteristic about them? Is there any piece of information I'm leaving out? And why might I be leaving it out? What is coming up for me? A colleague of mine said, would you say it to the patient's face? So I think the recommendation here is just to ask the patient what they like to be called, how they identify. And this is the same for infants. Parents are their spokesperson, and we can respect their name and the relationship. So that's all for me, and I'll pass it off to my colleagues. Thank you. I look forward to questions and discussion.
Thank you so much. So let me pull up and share, and then get myself together here. Okay, are you guys seeing my slides?
Yes.
Yes, okay, perfect. Okay, so I am here to talk about the impact of stigmatizing language on patients, families, and babies. So Veronica did such a good job talking about how we discovered there is a challenge and what's going on and kind of areas that we can improve on. But I'm always going to be the person in the room that says, hey, how does this impact the family? How does this impact the baby? I also care about my clinical colleagues, but and the rule of hierarchy, we're not the ones seeking care. So we need to make sure that we're being flexible to provide safety for patients and families when they're in their vulnerable moments. In that vein, there are a few things that I am going to ask you to just commit to as we are starting out here together. So some foundational perspectives that I'm asking us all to agree with and integrate into our practices and beliefs. So first is that all people are inherently worthy of high quality, inclusive, and affirming care. Regardless of what their status and their definitions and other descriptors are, I want to be able to provide care that is affirming of however they identify themselves. And then everyone you interact with has the potential to have experienced trauma. So since we know that, we can just act in a trauma responsive or a trauma informed way, and that way we're mitigating any compounding trauma that could happen from this medical stay. And then one of my favorite teaching points is remember that the baby is also a person. We do a lot and we talk about how this affects us as clinicians, how it affects the adult population, but we have to remember that the tiny little human that, we're all here to safely navigate into the world, also is a person. And we want to make sure that we're kind of centering their perspective and their needs, wants, desires, often spoken mostly by the family. So we can make assumptions on how things should go, but it's really down to the family for us to be able to hear and talk and listen to them so that we can honor their wishes and desires for their baby, because they are the voice for the baby. So our next, okay, there we go. So now we're going to talk through a couple of different foundational things to kind of brace my section. So first, I want to recognize that our words have power. So when we think about that, we have spoken words, we have unspoken words, and then we want to make sure we're eliciting preferences around how we use those words. We'll talk a little bit more about that in a slide. The next is the importance of partnership. I can't understate this more. Family partners, lived experience, like partnering with people who have the lived experience of the care that we provide, helps us improve and find gaps in the care that we know that we're trying to provide high quality care, but sometimes we fall short. And we have a choice there. We can then decide that that person's unreasonable and my intentions were to not hurt them, so they should just be fine. Or I can say, you know what? My intentions were not to hurt them, but harm still happened. So how can I learn from this to prevent harm from happening in future situations? And then everything that I do has a little bit of trauma-informed care because Mary Coughlin raised me well. So we want to talk about validation, resilience, and mentorship, at least briefly. So our words have power and we should wield it with intention. Whether we ask for that power or not, we have it, so we need to use it responsibly. So some examples of how our words have powers, they're verbal, written, and behavior, because not all communication is done with our mouth and our voice. A lot of it is done with our face, with our body, with the way we use our attention. And so all of these things work together to impact culture or the practice on a unit. So here's some examples that have a little more of a NICU or community-leaning lens, in addition to the ones that Veronica provided earlier. So using terms like 24-weeker, it's one of my big pet peeves. It's a hard habit to break. You'll still hear me say it sometimes, but it's really kind of dehumanizes the person from being an individual to being a category of person. Well, 24-weekers are going to 24-weeker. And you're like, okay, no, this baby who was born at 24 weeks or this 24-week person. It's a way to kind of force in some humility into how we care for these babies. And then the NAS baby or the NOWS baby, or God forbid, the drug baby. That kid with the genetic condition, the one down there, down the hall, the kid with that weird genetic condition, you might clinically know, but then that automatically makes this person only their diagnosis. Or not even remembering the name and just saying, hey, bed 24, they have a question for you and they need you to go back and talk with them. Or that primip. Especially on the, maternal side of things, it's easy to talk about how dramatic things are. She's going to have to push for so long. So then we're setting somebody up for a whole narrative when it might not even be our intentions to do so, but the impact to that culturally can cause some challenges, not only for not creating great culture on your unit, but also for the patient's experience, like the powerful story that Rose shared earlier, is that's the term that we use, but to hear your body be referred to as a failure over and over again has an impact. And then baby daddy. Now, some of these we know that we should not put in a chart, and we know we should not write down on sheets, but they get used frequently all the time in conversation. And it's just not our business, and it's not respectful, and it promotes a chance to be dehumanizing, even though we might think that we're being, we're kind of being colloquial or we're having like a little chat time, but that's not for us. When someone is seeking care from us, we have to have that respect for who they are as a person. Some behavioral examples. Closed stance. So, standing in the corner with your elbows, kind of tucked under your chest and kind of eyebrow. Maybe you're scowling a little bit. Maybe you're tired and you've had a long day and your face just can't be appropriate today. Well, there's a way that we can manage that or maybe remove ourselves from certain situations. No one expects us to be perfect all the time, but it's just when you notice it, try to make a correction. Not pausing or asking consent prior to touching. I might find it okay for a hug or a back pat or something like that, but someone else might not. So even when you're helping a patient move or reposition or things like that, you could say, hey, guess what? You might feel my arm right here. Is that okay? Because it gives them a chance to say, yeah, that's fine, or no, please don't touch me, right? And then not looking at the patient when speaking to them. This is really common in a fast-paced world of EMRs, and you're constantly charting and you're managing like 3 different pieces of technology at all times. And you might, be listening, but if you're staring over here at a computer screen the whole time someone's telling you, their traumatic birth story, it feels like, hello, or do you see me? And even as a clinician, I struggled with that when my time during the NICU, because I understand you've got 85,000 things to do, but can like 2 of them at least be look at me and pay attention for some of this so that I feel like I'm being seen as a human and not just another task that needs to be completed. So now let's talk a little bit about person-first strength-based language. So it's intentionally centering the person over their diagnosis or current challenge. So some kind of examples that reference from the slide before. So King, who was born at 24 weeks. Ava, who is experiencing NOWS. Mrs. Smith, the patient in bed 24. Mark is Caden's dad and Sarah's partner. So you're actually centering the humanity and the role that that person plays in this dynamic more than just a label that they get attached. And I can't say this enough, and I know this has come up in other FCC events, but make sure we're asking preferences. Some parents would prefer to use their first name. Some parents would prefer for you to call them mom or dad. Some parents have a different, name that they like to be called. Not all communities subscribe to person-first strength-based language. Some communities really strongly prefer their identity to be centered in discussions around them. An example of this is the autistic community. Of course, there's not everybody in the autistic community, but there are a lot of publications and op-eds shared about how the label of autistic person is more affirming to their neurotype than it is to say somebody with autism or the person with the diagnosis of autism. So you say, you take you give it a shot, you say, this is what I've got. And then that person, if you've made them feel potentially safe enough and vulnerable enough to be able to say, hey, I would actually prefer you not say it that way. I like it better this way. Then it's a gift because one, you've affirmed their identity, you've affirmed their role in the dynamic, and then you get to walk away with a new piece of knowledge. And as an educator, I always want to be able to walk away with a new piece of knowledge. AAP does have a good reference for this. It's called Words Matter. They did a campaign on inclusive anti-biased language. And so they have a bunch of videos and like tip sheets and kind of tip sheets to talk through how to integrate this into your practice. So when you do misstep, because you're going to be a person is to make a mistake, right? And so when you do misstep, you just go, you know what, thank you for letting me know. I'm going to do my best in the future. You don't make a big deal. You don't, get all sad and start crying. You just go, you know what, I didn't know that. Thank you so much. And just kind of move on so that we can move on with the interaction. So the baby is a person. We referenced this earlier. So they are deserving of autonomy and safety. We do this, we support this by using things like cue-based interactions. We know in the NICU we talk a lot about cue-based feeding, but really we should cue-based most non-emergent interactions, which if we're really being honest with ourselves, a lot of the care we provide, even in an ICU, isn't actually an emergency. There could be urgency behind it, and there could be a need for structure behind it, but we can still do those things from a cue-based perspective. Saying things like, hey, buddy, it's Jessi. I'm going to be your nurse today. I know I got to get some labs. I know it's not fun, but your mom is here and she's going to help us, keep you calm. I've got your passy. We're going to swaddle you and we're going to get through this together. That's saying that it's priming him for neuroconnection to say, I don't love this, but someone's here to help me on both sides. I know I still have to do this thing that I know hurts, but I'm trying to wrap that and buffer it from affection, both from me as a clinician, because I am fond of this baby, but also, most importantly, from the parent who loves him more than anybody else in this room, right? So it's being able to partner with them together and actively include them in the plan of care. Because that just as easily could have gone, well, we've got to get labs. Do you want to go to the waiting room and just wait? Because maybe you don't want to watch this. And we think we're protecting, but we could actually be promoting harm. So we are helping this baby and family build a brain and a nervous system. So what we do either helps or it harms them. There's no in between. We're either value added or we're value extracted. So we want to always come from a place of adding value to this family. I know sometimes that it can feel like, you've got so many tasks to do and it's just easier to do things to the baby. I've got to check this list. But we really want to try to shift that model from doing to doing with, so that we're in partnership always. Because look at this little baby. He is being held by what I'm presuming is a parent, maybe not, but being held by a parent, eyes wide open, looking out at the world and saying, hey, I'm here, I'm a person, and I'd love to be a partner with you. So we need to make sure we're seeing that. So now let's talk about the importance of partnership. We are all in this together. So partnering is a verb. Sometimes we don't think about it that way. We tend to want it to just be quick and over, but it is an active process. So family partnership councils, also known as patient family advisory councils, help us understand how our care is experienced. We must actively seek out the patient and parent voice, especially when it stings. We're really good at it when they want to tell us how amazing we are and bring us cookies. I have eaten the cookies, I have brought the cookies, I understand the love language of cookies in healthcare, but we also need to be willing for someone to say, you know what, this part was great, but this part was not good. And I would love for other families to not have to feel that way. But that means we have to be vulnerable on ourselves as a system to receive that feedback that might not be 100% glowing, right? And diversity matters when you're building these partnership councils, because you have to make sure you're having a diverse group in age, socioeconomic status, experience with social drivers of health, the NICU or their birthing experience. If you're only talking to people who are able to volunteer, you're already having a biased experience. Because the person who is able to volunteer both financially and with time and all those other things, transportation, they're having a fundamentally different experience than someone who intersects with those drivers of health in a little bit different way. So yes, it is more work on our part to seek this out and to make sure we're providing support, but we have to, so that we can say that we are doing everything within our power reasonably to provide safe, equitable care. So our next one is trauma-informed care. We all deserve a chance at safety. I specifically chose the word chance here because people are not safe just because we announce that they are safe. A felt sense of safety is deeply personal and is not always achievable based on who that person is and what their story is. Now, I'm not going to get too far in because I could talk forever about this and I've already talked too much, but I do want to call out a definition for trauma. So this comes from the Substance Abuse and Mental Health Services Administration. So it's individual trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Now, it's a lot of fancy words, and I really like how thorough it was, but it basically sums up to essentially it is whatever the individual experiencing it says it is. So when someone identifies something that we've done as being stigmatizing, as being harmful, as being offensive, we don't argue. We just say, you know what, thanks, and then try to move on and learn as much as you can about it. When you keep that perspective of I'm just here to learn, you're going to walk away with so much richer information to take for your practice, but also better clinical data, because your patient is going to feel like they can actually share with you rather than needing to act in a trauma responsive place. There are some principles to trauma-informed care. I almost never will talk about things in a hierarchy unless we're talking about Maslow's hierarchy of needs or presenting trauma-informed care responses, because things are built from a foundation of safety. And then when you have peers who understand what you're doing, and then you add trustworthiness and transparency, collaboration, and you build from there, you're actually building towards this kind of self-actualization, to borrow from Maslow's hierarchy, right? We can talk all day about how important these principles are, but until we actually put them into action, it's hard for patients to access them. So when we're talking about safety, they need to feel safe, hopefully physically at least, and then psychologically safe, or at least feel that we are trying to provide a psychologically safe environment. Peer support, I can't understate that. And I know many people, on the task force run organizations that help facilitate that. And I give all of the prompts and kudos to them. It's key for establishing safety and hope, most importantly. It's someone walking alongside you that says, I've actually been here and there is hope on the other side. We as clinicians can try to facilitate that, but we don't have the lived experience piece. So being able to walk along somebody who really understands makes a big difference. And then trustworthiness and transparency, there should be no secrets. We need to promote good communication forwards and backwards between patients, families, and clinicians. Collaboration and mutuality, we want to partner and level those power differences. And then cultural, historical, and gender issues, we have to understand that people are coming from intergenerational trauma and other challenges, and make sure that we're aware of those while actively working to dismantle those beliefs and biases. And then empowerment, voice, and choice. The organization should actively foster the belief and the ability to the desired of people that they serve to heal from trauma. We need to say that, we can come around from this. But if you start with empowerment, but they don't feel safe, it's not going to happen. They need to be able to feel safe in order to make that change. And then lastly, it's really just committing to a perspective shift. So we're going from what's wrong with you to what happened to you. So that kind of shift of something's missing. There's something missing here that makes this make sense, but I don't have access to it. And then we shift hopefully to what are your strengths and current capabilities and how can I help you? So we know that we shouldn't just yell, what's wrong with you? Although I'll be the first to say, sometimes I ask my kids that and then I'm like, oh wait, I tell people don't say that. Like it is an instinct, right? To not to say that, but we need to know something, there's more information available that makes this decision make sense. I just need to gain access to it. But that's what I have. And then I will transition over to Cheniqua, I believe. Do you want me to stay sharing or are we going to pause and do questions?
I think we were supposed to pause and do questions,
Okay.
but I do have the slides on my end, so you could
So I can stop share?
Yeah, that's fine.
Cool.
Yeah, we do have just a couple of questions. The first was, is ACOG or A1 working on changing phrases like failure to progress or cervical incompetence? Is anybody aware of a movement to do that?
I haven't seen anything come out from ACOG or ACNM on that specifically, but maybe one day.
I haven't,
Okay.
I haven't seen anything
Yeah.
either, but I have heard some intentional conversation around the use of, especially around the use of cervical insufficiency versus incompetent cervix. And that's been anecdotal. I haven't seen anything largely done, but I don't think anything's out there. But some people are individually saying, yeah, we need to change the language. But we'll definitely do some research and see what is out there.
Yes, definitely. And Jessi, how do you operationalize changing stigmatizing language in a unit?
So I'm going to, spoiler alert, I'm going to say
Or is that in the
my
next
colleagues
part?
because it's coming up and they're going to do a much
Okay.
better job at it than me.
Okay, fair enough. Okay. All right, well, that's all we had so far. So great so far. Let's move on.
I thought I saw a question about open notes that
Oh,
Melania had put in
yes.
there.
Oh, thank you.
And I think it's for you, Veronica, and your research.
Yeah,
Let
I'm not
me
actually
scroll
sure
back
if
through.
during
yeah.
the time when of the notes for our study, if those were open or not. So I apologize. I don't know the answer to that, but I can look at it. I do see another question. Someone says, I struggle with birthing person as opposed to mother and wonder about any pushback from anyone on that term. It seems to leave out adoptive mothers. That's a great comment. So I use the term birthing people and women both together to be inclusive of people who don't identify as mother. I understand that parent is probably more inclusive than birthing person. So I think it's really, this is just the academic terminology that I use, but I think that when interacting with folks and, it's a good consideration for me to have as well in future academic presentations or papers to expand that. So that's a good point. Thank you.
I agree with that. And having worked in an environment, in a setting where there was a fair number of parents who didn't identify as mothers, it feels to me like birthing people is a bit more inclusive. And I do tend to use the words together, women, parent, birthing people interchangeably. So I think it's helpful because the goal is always to make sure that somebody feels seen and feel heard and feel part of the conversation. Um, and I don't think using one term necessarily minimizes the other. I think there's room for all of us as it relates to terminology. So I lean on using all the terms because I want everybody to be a
Yeah.
part of this.
Yeah, no, thank you. I think that that's definitely something that I think comes across when people are uncomfortable with not being called mother, when it's something that they want to identify with, that saying birthing person minimizes that, but it doesn't. So it's kind of helping to kind of, I guess, flip that script. And like you said, Jessi, going back to asking what the preference is, right? I mean, that's the whole point when we're talking directly with families. Okay, it looks like yeah, it looks like that. Oh, wait, we do have one other comment. Um, what about adoptive parents? If you're looking at birthing person versus mother, not that adoptive parents aren't mother, but just want to address that comment that Carolyn put in the chat just now.
Yeah, I think especially when she clarified that, in policies and procedures and like how we formally
Mhm.
talk about it, that's where I
Mhm.
think we have some work to do to try to figure out what is the inclusive terminology. I know sometimes people will use caregiver, but then sometimes parents feel like that's not inclusive of them. I think sometimes it's just promoting, one, I have two thoughts, right? I'm a wordy person. I'm trying to be quick, but one, like we need to identify something that hopefully will be received well from the community as inclusive, but also the tone of the document and the encouragement in the document and how we do that, that should also speak to the inclusivity, right? So then the less likely the individual word could matter if the overall tone and passion and like culture of that document is, we want you involved in every single thing you want to be involved with,
Yeah.
because then I think that means that it's less rigid. I think a lot of times policies and documents are written to protect from a legal perspective, organizations and people, rather than figuring out how can we actually partner with the group that we're intending to provide care to.
Great, great insight. And Christy just commented, sometimes your state government mandates your language. I see
And
Rose nodding her head. Yes.
Yeah, I was thinking that part.
Yeah.
And it's difficult, right? I remember when the executive orders in January of 25, January, February, like one after another, after another, after another. And at A1, we had to make some decisions, right? And one of the decisions we made, I mean, the Association of Women's Health, women is in there. So it's like, you can't use women. Well, we're gonna continue to use women. We're gonna continue to use equity because that was important for us, right? We wanted to be that consistent, constant source of information for our nurses. But it is difficult when the state is mandating it and when you're relying on federal funding and needing to kind of skirt the issues. What I tend to tell folk, I sit on a couple of boards, what I tend to say is, if we can continue to do the work and just change what we call it, I don't care, right? At the end of the day, if we're doing the work and we're able to get the money to do the work that we need to do, call it something else. Let's not let a vernacular be the hill that we die on when there's so much more important things for us to do. But again, that's Rose Horton. That's free, but it's only Rose Horton's comments.
Thank you, Rose. Okay, last question so we can get to the rest of your group presentation. Jessi, can you share how you advocate if you see stigmatized language at the bedside when there's power dynamics?
Yeah, as my friend and colleague Mia Malcolm always says, shame is not a social justice tool. So we do not need to go in and shame someone and make them feel bad for a choice that they made. I personally am a big fan of role modeling. So if someone says, hey, that 24-weeker over there that's freaking out, I'll be like, oh, you mean that baby that's born at 24 weeks who's having a hard time and needs some comfort? And I'll just like very quickly in a non like judgmental way. I don't make it a big deal. I don't make them feel stupid, but it's just role modeling really quickly. Like, hey, let's spin that. So that you could see that, sure, maybe I used 5 or 6 more words, but it was inherently a more human-centered way to talk about that baby rather than just saying, oh my gosh, he just won't stop crying. Well, of course he won't stop crying because he's seeking social interaction. So let's go over and help him,
Yeah.
So it's kind of just actively shifting that over and then being the change, like actually trying to do it yourself. Most importantly, if you also make that mistake, own it and say, you know what, thank you. That one
Yeah.
slipped through and I thank you for calling me out, right? So that you can role model what it's like to be corrected too without having like falling apart.
Yes, absolutely. I've been gently corrected in many different circumstances, and I appreciate it because I don't want to be saying the wrong thing. I don't want to, like you also mentioned, intention and impact. We have to be able to accept those corrections with grace, with humility, and with gratitude. Well, thank you so much. Let's move on because I know there's so much more to be learned today.
Okay, can everyone see my screen? Awesome. So I just want to say thank you to everyone. This is such robust conversation, and I love it all. I'm here for it all. My name is Cheniqua Morales. I am actually not a NICU nurse, and I support all of you. Keep it going because I'm not that nurse. I am actually a labor and delivery nurse. I am happy to be here, but I will pass that baby to you quick, fast, and in a hurry. I appreciate all of you that respond to our L&D codes. You come quickly and we love it. And so thank you on behalf of all of labor and delivery nurses. I have the amazing, the blessing of working as a perinatal safety nurse now. And really what I do is my work really focuses on combining education, which I'm really passionate about, and quality improvement tools to really guide and implement change, right? So what I do is I really step into the role and I work with all of the teams. I work with OB, the OB providers, I work at the anesthesia team, I work with nursing, and I do some I have done some collaborative work with the NICU. And it's been very, very cool to be this one person that gets to bring all of these teams together to create this better experience for the patient, but also for us as the clinicians. And I was a labor nurse for 10 years. I was on the floor for 10 years. I've done postpartum, well baby, high risk postpartum, and then labor and delivery and a little bit of critical care OB. And so again, NICU was never my jam. They would float me there. I would freak out. I just wanted the growers and the feeders. That was it, right? But one of the things, regardless of where you work, is that all of this that we're talking about, when we're talking about stigmatizing language and we're talking about even the language that we use or naming things, I agree with Rose 110%. I actually received a grant a couple of months ago for a simulation project, and the original name of the simulation was Cultural Diversity Simulation Series. Guys, they gave me $41,000 and they asked me if they can change the name. Yes, you can change the name to whatever you want to change the name to because I'm still getting the money to do the things that I need to do to affect change. So I agree with Rose completely. I also want to take a minute to recognize that all of this that we're talking about, it's rooted in self-reflection, it's rooted in personal deep work, and it's rooted in culture change. And culture change is the most challenging part of leadership, and like regardless of where you work, but it's also the most rewarding. And in my experience in working with both formal and informal leaders, the best way to begin this type of journey is to start with why. When I say formal and informal leaders, it's because leadership is not just about titles, right? I'm a nursing leader, but it's not my title that influences or affects change. It really is the influence that people have. So, who are your key influencers when you're on your unit? Think about how their impact can support goal work, right? So, for example, you have your charge nurse, right? Everyone that's worked in the hospital has worked with someone who's in charge that has either made the busiest shift super doable, or what should have been the lightest shift extremely challenging, right? So remember to consider your influencers on the unit. Simon Sinek, he says there are only two ways to influence human behavior. You can manipulate it or you can inspire it. And if ever you've seen manipulated behavior always reverts back, right? But if you inspire it, that is a sustainable change. Everyone here has heard of buy-in, right? The leaders come up with an idea, they get the teams to get on board, they'll tell nursing, they'll tell the physicians, want everybody to buy into this idea. The team they may not, right? And when they don't, it's usually because we did not involve them in the process. Think about if you're a clinician, think about your experience with process improvement projects or changes that were made without your input. How did you feel when you showed up to the unit? You came in for your shift, and all these changes were presented, but you didn't have an opportunity to partake in the process planning. And you can literally look and say, this isn't going to work because you know what the barriers are and the nuances are on your unit, right? And I'm not talking about the pessimistic people, I'm talking about the people that really do want to affect change. So for real and sustainable change, we need our leaders and our frontline teams to take ownership, not buy-in. When they're included in the process planning, they become invested, and that's when the real magic begins, right? So we want to start by explaining the why behind the what. We want to also talk about findings, keep them involved, keep them abreast, share the vision of where you want to end up, and let them show you how to get there, right? So in order to do that, sorry, y'all, I think, yep, okay. In order to do that, we have to remember that we're working with adults. At least I'm an adult most of the time, but there are some days where I'm not a great adult, right? I'll kind of get a little whiny or get a little sad, and I'm just going to be very transparent. But think of yourselves, we're all adults. We're adult learners, and adult learners don't learn the same way as children, right? These are just some principles that are going to be foundational to any process changes when you're working with adults. These were developed by Malcolm Knowles, and they're really powerful. In his work, he really talks about he defines the art and the science of helping adults learn. He focuses on self-direction, you focus on life experience and immediate practical application. The thing is, as an adult learner, and I want you guys to put yourself in this scene, right? Me as an adult learner, I need to understand the purpose of why do you want me to learn this, right? Like why are we doing this? My mind is in overload. Quite literally right now, my daughter's on her way home from school. I want to make sure she's okay. I'm hungry. I'm not really hungry. I did eat, but you never know, right? You got all of these things in your mind that are kind of like sort of like open tabs in your mind. And so why is it that you are having me learn something new, right? And if I'm going to learn something new, I want to take ownership of my learning process, right? I also want to know that it's going to help me immediately. It's going to make my life better. And one of the things that I remember as a staff nurse is that they're always saying, yes, patient-centered care, patient-centered care. And I'm a deep believer in creating a very, very a safe space and a brave space for my patients. I am truly about that. The part that I felt was missing was who was pouring into me as I was pouring into them, right? And so really showing up for our staff and our frontline staff, let me help you make this relevant to how this is going to make your life easier. And then we have to remember that people are more motivated by internal factors than external pressures. So I'm the type of person that if you tell me I'm doing something well, I'm going to want to do it well again, right? That positive reinforcement and that positive feedback is going to help me know what I did right. And I'm going to want to replicate that. And so I am more motivated by that than I am by you yelling at me or telling me that I'm not doing good enough or we have those external pressures. I hope that makes sense, right? So to get here, you want to create what's called a just culture. And oftentimes we talk about a just culture, but practicing it is really, really important. And this is where leaders can come in, both formal and informal, and start to create this type of environment, right? It's an environment where individuals are treated fairly and not blamed for system issues, while still being accountable for their choices and behaviors, right? It's going to promote that psychological safety, that accountability, and that continuous learning that we all need to have in order to really get to a place where we are showing up fully for our patients. We're finding the right language for our patients, and more importantly, the right energy when we step into that room. So I have a couple tools that I'm going to share with you all. When you're building when you're building a culture of safety. So these are three concepts that when I'm working with my team, I really stay rooted in, and I think it sets the groundwork for creating that non-blaming environment, but it also keeps people open to accountability. And I've seen it work with my teams because I do a lot of work with them and I do have to call them out, right? Part of my work requires doing a significant amount of reviews and audits. I deeply do not like audits. They are time consuming and irritating, but they are important, so we have to do them, right? As a reviewer, I have two advantages, right? If I'm reviewing a case or reviewing an outcome, I have two advantages. One, I'm aware about stigmatizing language and best practice. We have to remember some people are not even awareness is the first step, right? So I'm aware, and I often go back to when I first started to learn about this because we asked a lot of questions about changing the language with AWAN and ACOG. This is all what we learn in academia. I learned this language in nursing school. So really, we are on a mission, all four of us, to get into nursing schools and start to share this work, right? But this was a learned behavior, but the beauty of it is that we can unlearn it. But just because I have unlearned it doesn't mean everybody else has unlearned it, right? And you can't tell me unlearn something without replacing it with something that I can learn. So that's one benefit. The other benefit is that I have the timeline in front of me, right? I am Monday morning quarterbacking. I can see the whole story, and I can literally sit here and be very judgmental and say, well, I have all this experience and I know this and I know that. And why didn't they do this? And why didn't they? Well, I wasn't in that clinical setting when it happened, right? So making sure that we're stepping into one, seek to understand. We need to make sure that we're creating psychological safety for our patients and our clinicians. If we don't, they're less likely to be transparent and they're going to fear retaliation, right? So I want to make sure that when I'm sitting there and I'm doing these audits or these reviews or doing a deeper dive to help them get to a place where they can improve their language, improve their clinical skill set. I want to make sure that I'm understanding from their perspective, right? The second tool is called the test of substitution. So what does that mean? It means would a competent employee with the equivalent level of training have done the same thing? Would you have committed the same error? If we can sit and put ourselves into the shoes of someone else, whether it's a patient, whether it's a staff member, whether it's anyone, if we can just sit and put ourselves in there and say, hey, would I have made the same mistake? Is it possible? And the answer is yes. Then more likely there's an opportunity at the system level with our leaders that there's something wrong. There's something we can fix at the system level if a competent person is making the same mistake, right? And then lastly, I look at the test of intention. Did the employee knowingly violate standards of care? And I think we need to think about this, right? I know most people do not show up to the bedside to say, hey, I'm going to be harmful towards a patient, or I'm going to be harmful towards my colleague. Most of us are in our own world going through our own things. And that's why I say it goes back to that personal deep work, right? But we really have to ask ourselves, did they come in intentionally wanting to harm somebody? And 99% of the time, the answer is no. All right. So when I'm sitting and I'm feeling all the feels as I'm doing my reviews or I'm hearing stories and I'm trying to stay objective, I keep these tools in front of me and I recenter myself by using these tools. And I think this is something that can be helpful both in life and on the unit. This is hard work to do. And I think when we start this type of work, we have to check our own attitudes because your attitude is going to determine your approach, and your approach is going to determine success or failure. If we come in being judgy and we're not, we're just kind of like this is how it is and this is what we should do. And we may not say that, but remember, communication is mostly body language. I forget the percentage, but it's really high. It's like 90% or something of communication is body language. So if I say, hey guys, we're going to come and we're going to do this, that's very different from, hey guys, we're going to come and we're going to do this. And I do have both personalities, just so you know, I'm an Aries, so I can do both. But I'm very mindful and I want to make sure that I come with that big positive energy, right? And so making sure that we're stepping in with the right attitude is really, really important. So the beautiful thing about this work is that we're not starting from scratch. There are tools already that have been developed, one of which is from the Alliance for Innovation on Maternal Health. They have free resources called patient safety bundles. They also have webinars and all kinds of amazing tools that can help you support your journey. Each of these patient safety bundles are a structured approach to improving care in terms of your processes and your workflows and your patient outcomes. And the beauty is that it's organized around what's called the 5 R's. So readiness, recognition, response, reporting, and respectful care. And they bring it all together so that as you're doing your reviews in whatever way that you're doing them or whatever case you're reviewing, it incorporates questions to ask yourself whether bias was a part of the care, and it helps you try to identify those key practices. So if you can take a look at that information, it's really, really helpful. Okay. Now, we're talking about stigmatizing language in the documentation, right? We're talking about reviews and audits, and it's a great place to start quantifying the work. But as you mentioned earlier, all of this is rooted in culture, attitude, and biases. These are really, really tricky and very hard to measure, but I don't think it's impossible. And the documentation is a really strong start of how we're doing it and to tell us if we're moving in the right direction. I do have so much more to share, but I think I'm going to speed it up a little bit. And you guys are just going to have to sign up for our program that we have coming because we have a series coming out that we're going to expand on this a lot more. But the part here is Dr. Neil Shaw, he said it best. He said, we can't fix what we can't see, and we can't see what we don't measure. So how do we go about looking and measuring? This is just one way that we decided that we're talking about to really measure our process as we move through this type of work. So first, you start by setting a very clear goal, right? In this example, the goal is to increase the percentage of charts free of stigmatizing language with strengthening a culture of respectful patient-centered communication, right? So let's say, for example, I was a labor nurse and I worked night shift for a really long time. If this is all rooted in my biases, right? Out of the abundance of the heart, the mouth speaks, and we put this into our documentation. So again, it goes back to what am I thinking? What am I feeling? And in that moment, let's say I have a patient with a very high BMI, right? I have been at 2 a.m. pushing with a patient with heavy epidural legs. I'm tired, or maybe we need to transfer her to the OR table. If she has a high BMI and a bigger body habitus, I had an attitude, full transparency, because I'm tired, I'm hungry, I want to go home. Why is she like this? And now we start projecting, right? And so if we can start to meet our teams, right, and say, hey, if you need a break, go take a break. If you need a minute, take a minute. But having that self-awareness, I will less likely be as irritated because I have self-awareness, and my documentation is going to show a little bit better that I am taking care of this patient free of bias as best I can, right? So what we want to do is, let's say, for example, we take that and we say, let's look at all of our patients that have a high BMI, a BMI of over 40 or whatever it is that you want to do, right? We can start doing chart audits and do what's called a run chart and start to see over time if there's less stigmatizing language based on whatever interventions we have been doing. So that might look like, starting a committee. It might look like having conversations during huddle. It might look like even saying, hey, let's not chart like this. Let's just state the facts, like Veronica said earlier, right? So if we start to see that, we can trend it and we can say, okay, we're getting closer to our goal of decreasing our stigmatizing language over time, which essentially should look like a difference or decreased stigmatizing actions in real time. I hope that makes sense. All right. So this is just one of the ways you can do qualitative reviews. You can do staff education and get debriefs and really just get into their minds, give them a space to talk and share. And I know our next speaker is going to share a little bit about what that looks like from a leadership standpoint. But really the goal is to create an environment where your actions or the actions of our staff and our clinicians can really be the best that they can through awareness and through hard conversations. And then we can start to track that and measure it and see if the interventions we're doing are making a change. With that, I am going to hand it over to my incredible colleague, Adrienne McIntyre, and she's going to speak a little bit more about leadership and how we can implement this on our units and in our places of work. So thank you all.
Okay, our screen? Yes? Okay, awesome. Thank you, Cheniqua. So yes, I'm going to talk a little bit more about the leadership experience. And, leading culture change is exceptionally difficult. And so we're bringing in a framework that focus on these 5 key behaviors that leaders can consider as they're looking to influence something that is as culturally ingrained as stigmatizing language. So I'm going to start with modeling the way. So all of you who are here today are now champions of a change. You have an opportunity to begin to look deeply at your organization and see how do we elevate or bring to the attention the change in the behaviors, the change in language that we want to see communicated to our families and our patients in the care environment in which we participate. And for those of you that are families, thinking about how your influence as a family member or have as a prior NICU family, how you can bring this type of information into a NICU that you influence. So when we're looking at this, we really want to make sure that we ourselves are very clear on what stigmatizing language is and our own personal beliefs when it comes to what we're going to stand for and the behaviors that we want to see not only in ourselves, but in others. So you're really looking at finding your voice so that way you can begin to explore where is stigmatizing language showing up for me. Am I saying, the 24-weeker over there or, that NAS baby, the way Jessi said, we're not perfect. We're imperfect people. And the more we know, the more we have an opportunity to change our own behaviors and then begin to model it and change the behaviors of others. So we want to make sure we're clear so that way we can be authentic in how we are not only leading, but when we lean into those uncomfortable moments where we need to bring correction, because the missteps are going to happen. They're going to happen all around you. And the more that you know and you are exposed and you start to listen for it, the more you're going to hear. And so because we're not using shame, we want to flip to reframe, right? So Jessi gave us a great example of I'm not shaming, I'm reframing. And I myself am going to commit to aligning my words and actions. So that way we can start to reiterate the importance of the power of our language and how we can implement a change through leading and modeling the way by our own examples. So we're looking at our own documentation, we're looking at our own ways of engaging, we're looking at our own bedside report, and we're saying, okay, what can I do differently? How can I reframe it? Okay, no, this child, their name is Adrienne, and she is a child that was exposed to opioids, right? But she has a name, she is a person, so we're going to be modeling that. We're developing a shared vision. So we're asking all of you to come on this journey with us in creating this vision of NICUs, of care environments, of labor and delivery units, obstetrical care that is free from stigmatizing language. So you have a unique position to help inspire this vision in others. So we're challenging all of you to envision this future in a way that you can start to excite the possibility in the others that you work with. So how do you appeal to this shared aspirational goal? Because it's big. We're saying it's culture. This is deeply ingrained. I am fully guilty of saying the wimpy white boy. I acknowledge it. I am. And then, but it also implies that because that NICU patient is a wimpy white boy, that they inherently need more care than the strong Black girl over there, because Black girls fare better, right? So I've now implied that one patient needs more care than another. So we're reimagining it, and we're asking all of you to pause with us and ask, why not us and why not now? So you're helping to come together to start to shape new norms and new behaviors by listening deeply to what could be in your own unit and taking this idea and concept and starting to share it with others. So like Cheniqua said, we have people that they're going to support what they help to create. So please share this information with others. They're going to want to know, though, what's in it for me. So if I'm buying into it, what's in it for me? Well, what's in it for them is going to be creating this trauma-free care environment that Jessi was talking about, right? It's creating a place where we're optimizing outcomes because we're prioritizing language just as much as we're prioritizing evidence-based practice. So think about that in the care environment in which you work. We're asking all of you to challenge the processes. You're going to be searching for opportunities and innovative ways to leverage the quality improvement or performance improvement process that Cheniqua was talking about. And that's going to really require us to think outside of our normal solutions in order to really move language and behavior forward. So we are the owners of challenging the process. So we're not following into, oh, that's just the way we've always done it, or that's just the way we do it here. We're really challenging that thinking. And we're ensuring that those that are a little bit more resistant, oh, am I really harming somebody by saying XYZ about them? Am I really harming that baby by just calling them the 24-weeker over there? Well, possibly or potentially. And do you want to be complacent in that? And so we're challenging those norms that we've all grown up in, or that we've all experienced as parents within the NICU. So we're searching for those opportunities. And it can start small. I mean, just shifting how we do rounds. We're going to commit to, when we round with our NICU families, when we round and we talk about the medical care of our patients, we're going to use the baby's name. Period. End of story. And you can track how often are you doing it? Are you doing it successfully? Did you integrate their name every time, every day? And that helps to promote the consistencies that we need to help address stigmatizing language. And we can address it early and we can address it fairly by describing what the norms are going to be within our unit. And then experiment with it, take some risks. You know, we're no longer going to use X term, we're going to move to this. And so how do we integrate that and be consistent so we can generate those small wins and generate new behaviors? I have to say, when people, when the terminology around birthing person, birthing people, when that started coming forward, I was like, oh, this is really clunky. I don't think I can buy into this. And now it is part of my standard language in such a way that I freely, much like Rose, I freely float between, okay, I have a birthing person here, I have a woman here, I have a mother here, I have a surrogate here, you know, and I can freely navigate between the various terms, gestational carrier, ensuring though that I'm first asking the patient, is this how you want to be referred to? So considering how you can reinforce through those small wins, and it doesn't have to be overly complex. You can start small, like Cheniqua was saying, finding one patient population that you want to hone in on, integrate it into huddles and rounds, and consider how you can do it every day, every time. We want to enable others. So we want to enable by creating a space for belonging and psychological safety. So I love the FCC because you start with that as your foundation in how you even introduced us today. We're all here first name basis because no one is more important than the other. We want to enable all of us to speak up because this helps foster the collaboration and the psychological safety, the trust that we need to really dig in and have those conversations. It also gives us that space when I fall, that Jessi can say, hey, Adrienne, you tripped a little bit over there. You may have fallen, but I'm here to walk alongside of you and I'm going to help strengthen you up because I am giving you a little bit of self-awareness here so that way you can have more determination and competence to do it differently the next time. So we're enabling each other by coming alongside. We're creating space to preserve dignity while we're maintaining a coaching and mentoring type atmosphere. Understanding, again, nobody's perfect, but we want to have this mutual dependency and accountability that we're all in it together and we want to see it improve. And so because we're going to do that, we're going to uphold others, we're going to uphold ourselves. It's not about competition. Oh, I did it right and you did it wrong. This is really about how do we leverage those tools in an empathetic way so that way we can not only clarify the expectations of our fellow team members, but we create the conditions for staff of all ranks. It doesn't matter if you are the housekeeper, the unit secretary, it doesn't matter your role, that if you hear it, you say something without fear of retaliation. And so that really goes back to that just culture, that everyone's voice matters. And lastly, in this space, we're asking that you encourage the heart. We want to acknowledge and show appreciation to those that are really contributing to moving the work forward with excellence. We want to really promote this. How do I say this? We lean into the fact that because it's culture work, it's going to take a long time. And so by encouraging the heart, continuing to show appreciation, celebrating those small wins over time, that keeps people engaged in such a way that they want to lean into it over this long duration, because this isn't a one and done QI project sort of thing. This is something that you may have to keep revisiting. And as terms change, as culture change, as language evolves, we're going to continue to revisit this because what was stigmatizing today and we make a change and the new language we adopt may then become something that could be improved or iterated on because language is constantly evolving to align with the needs of our community and the population that we serve. So we want to incorporate meaningful recognition so that way we can keep our teams moving forward towards that shared vision and the values that we said that we wanted to model when we first set out. So I'm going to end with this call to action. I want you to start listening. Just start listening for stigmatizing language, the failure language, the labeling with diagnoses over names, and just start listening for it. Then I want you to imagine, what could it look like to create an environment with some key stakeholders and champions who want to make a difference? Then start to think about how could we simply measure some of the stigmatizing language that may be occurring in our unit. Is it within rounds? Do we want to do an audit tool like Cheniqua said, while we're looking at a subset of our population and looking at charts to see how often is it occurring? Because again, we can't change what we can't measure. And then I want you all to start modeling the way and enabling others to do the same. And then lastly, celebrate the small wins. Every step forward is a victory. So just keep channeling that. And we're here to support you along the way. And I'll stop there and see if there's any time for last minute questions.
Yeah. We do have a few comments, a few questions, and we may go over a little bit, but this is all recorded. Be sharing it out on Tuesday. A question for Cheniqua, because obviously, as you mentioned, this is work that requires self-reflection. What do you do when someone is not willing to be self-reflective, or perhaps at the reason behind their unwillingness is fear? How do you work through that with somebody?
I think the reason is always fear, because it's courage, right? It's brave work.
Right.
I will answer, but I also want to pass that question to Adrienne because I think she can expand on it. I think that in this work, we're here, those of us that are here, we're here for the long term, right? Like we're here for the long view. And for me personally, if I'm here for the long view, one, I'm in Aries. I have a lot of energy in the beginning and then I stop, right? But that's if we're here for the long view, I make sure that I'm around people and I work with people, particularly at my hospital and at my team that want to work with me. And so there's something, and I should have put it in this slide deck, but there's something called a bell curve, right? And you have your innovators that are kind of at the beginning. The bell kind of looks like that, looks like a bell. And at the beginning of this bell curve, you have your innovators, then you have your early adopters, the people that are willing to change because they're excited about it, right? The innovators, they're ready to make it up and figure it out and go. Then you have your late adopters. They're just kind of watching because they're cautious and they don't know if it's going to change, not change, how is this going to go? And at the end of this bell curve, you have your laggards. You have the people that are likely not going to change. And if they are, it's no time soon. And oftentimes we spend so much time with the people that like, oh, they need this. Oh, they got to have this. And and that can be draining, quite honestly. So for me, I spend more time when I'm doing any sort of project or goal work with the innovators and the early adopters. I run with people that run with me. Then the late adopters eventually, they catch on. And then you have your laggards that some do, some don't, and that's okay. But I think Adrienne has a much better answer regarding the laggards than I do.
Sure.
So I'm
Great.
gonna
Thank
pass
you.
it to Adrienne.
Yeah,
Thank you.
I second Cheniqua. We do in healthcare tend to spend a lot of time on the laggers and the resistors. We want to somehow convince them that our way is better, and we provide them all sorts of rationale as to why they need to make a change. And we want to start quality improvement. We always want to anchor it in the why. And if there is a what's in it for me, we want to put that forward. In this particular type of work, if you spend too much time on the laggers, you miss out on the momentum you could have with the innovators and the early adopters because they are going to shift the culture. And the more they shift the culture, you'll be surprised, especially with language, how people start to acquiesce. They acquiesce to what is being perpetuated in the environment in terms of the language. So I do agree with you, Cheniqua, that if we overcommit to the laggers, it will suck a lot of the energy out of this work. So there's that piece. The other piece is within documentation itself, we have a lot of defensive documentation that you see in the medical record, right? Parents refuse to participate in blah, 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 right? And it's because what we're really trying to convey is we gave them an opportunity or we talked to them about risks and benefits and that they made a choice. And so that defensive style of documentation, that's another piece of it that we want to tackle. And it's a little bit different than what's happening verbally, but it's all of it together that constitutes stigmatizing language. So we have a larger issue within healthcare that drives defensive documentation, but that doesn't mean you can't start now and you can't have those small wins.
Yeah, great. Thank you so much for that. I appreciate that. We did have a comment a little bit earlier, really kind of reflecting on current learners and kind of newer or younger staff, the pre-pandemic or, folks, and how you address that, or do you, when you're looking at the learning, adult learning. Yes, Cheniqua?
I just wanted to say, I just wanted to say
Oh, sorry.
piggyback off of Adrienne. I think
Yeah.
those small wins, she talked about small wins. We have to make those small wins huge. We have to celebrate those small wins because I think that's one of the things that's going to keep you going. It's also going to keep your people going. And taking that, the smallest thing. I remember being in nursing school and I was like, well, I passed my test. I'm closer to my boards. That one exam, right? Like make it big. So I just wanted to emphasize that a little bit. I'm so sorry.
No, thank you. I appreciate the emphasis. Did anybody have any comments about kind of when you're looking at changing this culture, changing language, when you have, a variety of learning styles and ages, particularly with these very short attention span?
I do. I am not opposed to small examples and small bite-sized pieces, because when you look at something like stigmatizing language or culture work, more generally speaking, it's really big. I mean, these are iceberg type things. So we're chipping away at it. So I really like Cheniqua's example of choosing a subset of the population to influence first, right? So making it bite-sized and more digestible. I'm also not opposed to using TikTok-like learning platforms, right? Where you're giving small bite-sized pieces and practical ways that people can lead in this space. I also think our newer nursing generation is not as, they haven't been ingrained so much in the way I was trained. And actually, I find them a little more adaptable with their language than our more tenured care providers. 20 years ago, what we said is not the same as what we say today, but I'm just finding that our younger nurses that are entering the profession, our younger clinicians, they're a little more adaptable to things like reducing the hierarchy and using first names. They're a little more adaptable to more inclusive language, because that's part of what they have grown to expect. So I'm curious to see, as quality improvement goes on in this space, if it's really going to be that which generation is going to have the hardest time. And I have to say, my hypothesis is that it's those of us that are 20 plus years into this,
Sure.
Have a lot more to unlearn than those that are now entering the profession.
Oh, yeah, I absolutely. I think that's a really good point. Definitely see it with my own former preemies who are 19, and one of them came out as non-binary. It took me forever for them to be natural, but for their twin, see, I still do it. For their twin, it was instantaneous because they're used to it. So it's nice to think about that outside of just the, that language, but that this is also kind of expanding throughout all the industries that these young adults are entering. There was one comment that I thought, I know Malathi is going to close us up here in just a minute, but there was one comment I did want to make sure that we got to, because I think it's really important. Ramya shared, sometimes we're on teams that may be making a lot of headway, and then leadership change occurs, sometimes over and over again and in a short time frame lately. And the work we were doing is derailed because it may not be the new agenda. So how does one keep going and stay resilient when the vision keeps changing and our seat at the table or worth may be on shaky ground?
I'll weigh in, because I'm in an executive director role and I help create goals for my organization. And one thing that I have found I am responsible for is, even when larger organization goals shift or change, if there's momentum in a particular area, my whole job is to find a way to link it to the new organizational goal. I find it really important to do that, because you can create a tie-in. So multiple states have CMS requirements around health equity work. Why not use this as your goal within your unit to tie back to that work? So there are ways to create those linkages, but that's what really adept leaders are good at doing, is ensuring you preserve that momentum by continuing to shift your story to keep it aligned with the organizational goal. So it can be done, but it does take some intention on, okay, knowing what's coming and how do I keep this work at the forefront. And sometimes I may be talking about it as it relates to health equity. Sometimes I might be talking about it as it relates to a particular care outcome that we want to influence, but this is a tactic or a strategy within that. And And that is a piece of leadership that some leaders are really quick to abandon because they can't create that connection. But if they're adept leaders, they can create those meaningful connections so that the work continues despite changes in government, changes in, and Rose has done that with AWAN, right? How do you keep diversity, equity, and inclusion? How do you keep a space for that when, now we're required to use different language? Well, the work didn't go away. We just shifted so that way the work could continue, while also, understanding that some of the politics are maybe requiring us to call it something different, but the work is still there.
Can I just add to what
Yes, go
Adrienne
ahead.
is saying? I think also there's an opportunity for informal leaders. I remember being at the bedside and just wanting to know what could I do differently within my care, right? And I think that, to Adrienne's point, when we find the core values of these organizations and link whatever our goal is. For example, I remember I really wanted to talk about equity and in 2020 when I actually only first learned about all the injustices in 2018, and I had been a nurse since 2012, right, towards Black women and Black working people, and I didn't know. And when I did find out and I started to learn more about it, it was around 2020 and COVID and all the events of that time, and I wanted to do something. And I ended up getting a job in quality, and the job that I had, they said, yeah, we want to do something too. So we want you. And I was like, yes, I found my people. This is great. I came to find out that it was sometimes can be performative sometimes, right? And what did I do? As I started to learn, I said, well, the work still needs to get done. What do organizations like? What is the safe thing that I can do? And so I started looking at simulation, and I really like training and simulation. And so I started using training and simulation to now push the agenda of sharing and spreading and making sure we were showing up better for our Black birthing patients, right? So you got to get creative with it. It doesn't, to Adrienne's point, it doesn't stop the work. It's just, okay, how do I link what I know needs to happen with what they say they want to happen? Everybody loves simulation. No one's going to say no. So find that thing and sort of link it. So you just got to get real creative about it. And then also, I would say keep showing up to events like this. This is where you find your people. Stay with people that are going to keep filling your cup, because I think that is essential for whatever, way that you decide to go and continue in this work.
Thank you. Rose, did you want to add anything?
I'll just add briefly. I think it really does depend on the level of leadership. I'll tell you, when I was an executive leader at the hospital, we had a whole initiative over 5 years that we did, and we became part of an academic medical center, and so much oversight, but nobody knew what we were doing because we're really focused on the patient and patient-centered outcomes. And I remember someone invited us to do a webinar for the entire system about our work, because word got out of the amazing things that we're doing. And I remember doing that webinar, and several CNOs called and like, we didn't know you were doing that. Like, yeah. However, we were getting it done, right? Because it was the patient-centered, necessary thing for us to do at the time. And I really believe that we need to ask for forgiveness instead of asking for permission as it relates to patient-centered outcomes. And we got so much love for the project that we put in place that we just said it was important for our service line. And we had the receipts, we had great data, and we had patient satisfaction that was wonderful through a pandemic. We had all the things to show. So, and we didn't need the bigger academic partners to tell us what to do. We took the initiative on our own, and it was like the best 5 years, I would say, in my career, just doing all the amazing things.
Wonderful. Thank you so much. Malaki, you ready to close us? I
Yes.
don't want to close us up. I would like to
I
keep
know.
talking to
It's like
you. My
it's
goodness.
so fantastic. And we are like 15
Yes.
minutes past the closing time, and we are like still like 70 people here. Thank you
Yes.
so much for all of you. And it's like excellent panel presentation. I'm going to go back and then listen to it. I think there's so many pearls and wisdoms we can learn from all of you. Thank you. Thank you. And so everyone, tomorrow is the International Kangaroo Care Day. So please celebrate and connect those mamas and dads to the babies. So celebrate that. And then next week, in the FCC Community Exchange, we're going to talk about how to overcome the barriers. So just join us, and it's not going to be recorded. So if you wanted to listen directly from our facilitators, join the session. And thank you again for all the speakers, and have a great evening. Bye.